Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of the management of pediatric empyema. We will work through 15 high-yield clinical cases covering the full spectrum of this important condition, from initial diagnosis and physical examination findings through pathophysiology, diagnostic imaging, pleural fluid biochemistry, antibiotic selection, drainage strategies, complications, microbiology, and long-term follow-up. This lecture is designed for general pediatric physicians and follows evidence-based protocols. Let us begin. Case 1. A 4-year-old boy presents with 5 days of high-grade fever and productive cough with increasing respiratory distress. He was treated with oral amoxicillin for 3 days at home, but showed no clinical improvement. On examination, he is tachypneic, with decreased breath sounds on the right side and a dull percussion note over the right lower chest. Chest X-ray reveals a moderate right-sided pleural effusion with blunting of the costophrenic angle. Which of the following is the most likely diagnosis? Option A, simple parapneumonic effusion. Option B, viral pneumonia with reactive effusion. Option C, empyema thoracis. Option D, pulmonary tuberculosis. The correct answer is option C, empyema thoracis. For features in this case, point directly to empyema rather than a simple parapneumonic effusion. First, persistent high-grade fever despite 3 days of appropriate antibiotic therapy. Second, progressive respiratory distress with decreased breath sounds indicating significant fluid accumulation. Third, pleural effusion on chest imaging in the context of pneumonia. Fourth, failure to improve with standard community-acquired pneumonia treatment. This pattern of antibiotic failure combined with a persistent effusion is the clinical signature of empyema. Simple parapneumonic effusions typically respond to antibiotics alone, while empyema represents infected pleural space that requires drainage in addition to antibiotics. Case 2. A 6-year-old girl with community-acquired pneumonia treated 10 days ago remains febrile and tachypneic. She complains of sharp right-sided chest pain and refuses to lie on her right side. Physical examination reveals decreased breath sounds on the right. Follow-up chest X-ray shows a large right-sided pleural effusion with meniscus sign. What is the next best step in management? Option A. Continue oral antibiotics and reassess in 48 hours. Option B. Order a computed tomography scan of the chest with contrast. Option C. Perform diagnostic thoracentesis. Option D. Insert chest tube immediately. The correct answer is option C. Perform diagnostic thoracentesis. Persistent fever and respiratory symptoms 10 days after pneumonia with a large pleural effusion require immediate fluid analysis to distinguish simple parapneumonic effusion from empyema. Thoracentesis provides critical diagnostic information that directly guides treatment decisions. The most important parameters to assess are pleural fluid pH and glucose. In simple parapneumonic effusion, the fluid is clear and straw-colored. pH is greater than 7.3. Glucose is greater than 60 milligrams per deciliter. Lactate dehydrogenase is below 1,000 units per liter, and white cell count is below 15,000 per microliter. In complicated effusion or empyema, the fluid is turbid or purulent, pH is below 7.3, glucose is below 40 milligrams per deciliter, lactate dehydrogenase exceeds 1,000 units per liter, and white cell count exceeds 15,000 per microliter. Cell count and differential also guide antibiotic selection. Case 3. A 5-year-old girl presents to the emergency department with severe respiratory distress. She has been unwell for 8 days with fever and cough, initially treated with oral amoxicillin without improvement. On arrival, she appears toxic, has significant work of breathing, and is using accessory muscles. Chest examination reveals absent breath sounds on the entire right hemithorax with marked dullness to percussion. A chest X-ray demonstrates a massive right-sided pleural effusion occupying more than 2/3 of the hemithorax. What is the most likely finding on examination of the trachea in this patient? Option A. Trachea remains in the midline position. Option B. Trachea is deviated toward the affected right side. Option C. Trachea is deviated away from the affected right side. Option D. Tracheal position cannot be assessed clinically. The correct answer is option C. Trachea deviated away from the affected right side. Large pleural effusions in empyema cause significant volume displacement, pushing the mediastinum away from the affected side. This results in tracheal deviation toward the unaffected side, which in this case is the left. Tracheal deviation occurs with effusions generally exceeding 500 milliliters and is a sign of significant volume effect requiring urgent drainage. Vocal resonance is severely diminished over the fluid because fluid damps sound transmission. Together, Tracheal deviation away from the affected side and absent breath sounds with stony dullness constitute the examination triad of a massive pleural effusion. This is distinct from pneumothorax, where the trachea also deviates away from the affected side, but percussion yields hyperresonance rather than dullness. Case 4. A 5-year-old boy presents to the emergency department with a 7-day history of fever, productive cough, and worsening respiratory distress. He was initially treated with oral amoxicillin for 4 days without improvement. Physical examination reveals tachypnea and decreased breath sounds on the right side. The physician proceeds with percussion examination of the chest. Which of the following percussion findings is most characteristic of pleural effusion in this patient? Option A, hyperresonance on percussion. Option B, normal resonance bilaterally. Option C, tympanic sounds over the affected area. Option D, dullness to percussion. The correct answer is option D, dullness to percussion. Dullness to percussion is the most reliable physical finding in empyema and pleural effusion. It occurs because pleural fluid displaces air in the pleural space, and the dense fluid prevents sound wave transmission, resulting in the characteristic stony dullness note. Normal lung percussion produces a resonant note, consolidation produces a flat note, and pleural effusion produces a dull to stony dull note. A key clinical pearl: dullness extends higher posteriorly than anteriorly due to the gravity-dependent distribution of pleural fluid. This is why examining the patient from behind and percussing from the top downward is the most sensitive approach for detecting the upper border of an effusion. Hyperresonance would indicate pneumothorax, not effusion. Case 5. A 5-year-old girl develops empyema following inadequately treated pneumonia. Her physician explains the disease progression to the parents during rounds. Which of the following best describes the correct pathophysiological progression of empyema? Option A, inflammatory then necrotic then fibrotic. Option B, transsudative then purulent then septate. Option C, reactive then suppurative then consolidating. Option D, exudative then fibrinopurulent then organizing. The correct answer is option D, exudative then fibrinopurulent then organizing. This 3-stage progression is essential to understand because stage determines management. Stage 1 is the exudative stage. A sterile inflammatory response produces clear fluid with low cell count and pH greater than 7.3. Clinically, the patient has fever and pleuritic pain in response to antibiotics alone. Stage 2 is the fibrinopurulent stage. Bacterial invasion and fibrin deposition lead to turbid fluid with high neutrophils and pH below 7.3. Persistent fever, septation formation, and loculations develop. This stage requires drainage plus fibrinolytics if loculated. Stage 3 is the organizing stage. Fibroblast proliferation creates thick viscous fluid and trapped pockets with a fibrous peel encasing the lung. This produces lung entrapment, restrictive defect, and chronic symptoms. Surgical decortication may be required. Early recognition and treatment prevent progression to the organizing stage with permanent lung impairment. Case 6. A 6-year-old boy with suspected empyema undergoes contrast-enhanced computed tomography scan of the chest. His symptoms have persisted despite 5 days of antibiotic therapy. An initial chest X-ray showed a large pleural effusion. Which of the following computed tomography findings is most specific for empyema? Option A, ground glass opacities in lung parenchyma. Option B, horizontal air fluid level in pleural space. Option C, split pleurosign with thickened pleural layers. Option D, mosaic attenuation pattern in lung fields. The correct answer is option C, split pleurosign with thickened pleural layers. The split pleurosign is the most specific computed tomography finding for empyema. It is characterized by enhancement and thickening of both the visceral and parietal pleura, which appears separated by infected fluid on contrast-enhanced imaging, giving the appearance of split or separated pleural layers. This finding has 3 important clinical implications. It is highly specific for empyema, distinguishing it from simple transsudative effusions. It indicates active pleural inflammation confirming the diagnosis, and it guides treatment decisions, indicating that drainage is required. Ground glass opacities reflect parenchymal lung disease. Air fluid levels suggest bronchopleural fistula or gas-forming organisms. Mosaic attenuation indicates small airway disease, not empyema. Case 7. A 5-year-old girl with suspected empyema undergoes thoracentesis. The pleural fluid analysis reveals the following results: appearance turbid and yellow-green, white cell count 45,000 per microliter with predominantly neutrophils, protein 4.2 grams per deciliter, and lactate dehydrogenase 2,800 units per liter with serum lactate dehydrogenase 450 units per liter. Based on these findings, which additional biochemical markers would most strongly support the diagnosis of empyema? Option A, high pH greater than 7.4 and high glucose greater than 80 mg per deciliter. Option B, low pH below 7.2 and low glucose below 40 mg per deciliter. Option C, normal pH 7.35 to 7.45 and normal glucose 60 to 80 mg per deciliter. Option D, variable pH and elevated glucose greater than 100 mg per deciliter. The correct answer is option B, low pH below 7.2 and low glucose below 40 mg per deciliter. The pathophysiology explains why both values fall in empyema. Bacterial invasion of the pleural space triggers intense inflammatory responses. Neutrophils consume glucose through anaerobic glycolysis, depleting glucose levels. Simultaneously, bacterial metabolism produces organic acids, which together with neutrophil glycolysis significantly lower both pH and glucose in the empyema fluid. The critical diagnostic thresholds to memorize are pH below 7.3 indicates empyema, glucose below 60 mg per deciliter is abnormal, and a pleural fluid to serum glucose ratio below 0.5 supports the diagnosis. Pleural fluid pH is the single most important diagnostic parameter and the best predictor of which patients need drainage. Case 8. A 7-year-old boy presents to the emergency department with a 6-day history of fever, productive cough, and progressive respiratory distress. Initial chest X-ray shows a large right-sided pleural effusion. Thoracentesis reveals purulent fluid with pH 6.95 and glucose 25 mg per deciliter. Blood cultures are pending. He has no known drug allergies and no recent hospitalization. Which is the most appropriate initial intravenous antibiotic regimen for this patient? Option A, amoxicillin clavulanate alone. Option B, ceftriaxone alone. Option C, clindamycin alone. Option D, ceftriaxone plus vancomycin. The correct answer is option D, ceftriaxone plus vancomycin. Initial empiric antibiotic therapy for pediatric empyema requires broad-spectrum coverage targeting the most common pathogens. Ceftriaxone provides excellent coverage for Streptococcus pneumoniae and most gram-negative organisms, covers penicillin-resistant pneumococci, and penetrates the pleural space effectively. Vancomycin is essential for methicillin-resistant Staphylococcus aureus coverage, which is increasingly prevalent in community-acquired pediatric pneumonia complications. The decision algorithm is suspected empyema, initiate first-line empiric therapy with ceftriaxone plus vancomycin, covering both Streptococcus pneumoniae and gram-negative organisms, as well as methicillin-resistant Staphylococcus aureus. Ceftriaxone alone or clindamycin alone are insufficient because neither provides adequate coverage against both pneumococcal and methicillin-resistant Staphylococcus aureus organisms simultaneously. Therapy is then narrowed based on culture results. Case 9. A 5-year-old girl with empyema undergoes chest ultrasound after 48 hours of chest tube drainage with minimal output. The ultrasound reveals multiple fibrin strands and thick septations creating loculated pockets of fluid throughout the right pleural space. Her fever persists at 38.5 degrees Celsius despite appropriate antibiotic therapy. What is the most appropriate next step in management? Option A, continue current chest tube and monitor for 24 hours. Option B, remove chest tube and start oral antibiotics. Option C, administer intrapleural fibrinolytic therapy. Option D, proceed immediately to video-assisted thoracoscopic surgery. The correct answer is option C, administer intrapleural fibrinolytic therapy. In fibrinopurulent empyema with extensive septations and loculations, simple chest tube drainage alone is often insufficient because the fibrin strands block fluid flow. Intrapleural fibrinolytics address this directly by dissolving fibrin septations and loculations, improving pleural fluid drainage, reducing the need for surgical intervention, and decreasing hospital length of stay. Available agents include urokinase at 40,000 to 100,000 units, or tissue plasminogen activator at 4 to 10 milligrams. Both are administered twice daily for 3 days, with the chest tube clamped for 2 to 4 hours after each dose. The management pathway is empyema diagnosis, chest tube placement. If poor drainage with loculations, then add fibrinolytics. Then reassess in 48 to 72 hours. Video-assisted thoracoscopic surgery is reserved for cases that fail fibrinolytic therapy. Case 10. A 6-year-old boy with empyema undergoes chest tube insertion for drainage. On post-procedure day 2, he develops a new continuous air leak through the chest tube system, persistent fever of 39 degrees Celsius, and worsening cough with purulent sputum production. Initial improvement after tube insertion was followed by new-onset continuous bubbling in the water seal, a temperature spike despite antibiotics, and productive cough with thick secretions. What is the most likely complication that has developed? Option A, pleural thickening and scarring. Option B, empyema necessitans. Option C, recurrent pleural effusion. Option D, bronchopleural fistula. The correct answer is option D, bronchopleural fistula. A bronchopleural fistula is an abnormal communication between the bronchial tree and the pleural space. The four classic clinical indicators of this serious complication are persistent air leak through the chest tube creating continuous bubbling in the water seal chamber, ongoing fever despite antibiotic therapy indicating continued septic focus, new or worsening cough due to pleural fluid entering the airways, and purulent sputum production from the infected pleural contents. This complication occurs when the empyema erodes through the visceral pleura into the bronchial tree. Management requires urgent bronchoscopy to identify the site of communication, continued pleural drainage, and often surgical repair. The key distinction from simple drainage failure is the presence of an air leak, which is pathognomonic for bronchopleural fistula. Case 11. A 4-year-old girl who recovered from empyema 6 months ago returns for routine follow-up. Her parents report she has been active and playing normally with no respiratory complaints. Physical examination reveals clear lung fields bilaterally with good air entry. Chest X-ray shows complete resolution of the previous pleural effusion with no residual changes. Pulmonary function testing shows normal spirometry values with forced expiratory volume in 1 second and forced vital capacity within normal limits for age. However, the lung clearance index is elevated at 8.5, with normal being below 7.0 for this age group. What does the elevated lung clearance index most likely indicate in this patient? Option A, normal lung function recovery. Option B, residual pleural thickening. Option C, early airway disease. Option D, restrictive lung disease pattern. The correct answer is option C, early airway disease. This case illustrates a critically important concept in post-empyema follow-up. Normal spirometry results do not rule out subtle lung impairment following empyema. The lung clearance index measures ventilation inhomogeneity using inert gas washout technique and is significantly more sensitive than spirometry for detecting early changes in small airway function and ventilation distribution abnormalities. An elevated lung clearance index with normal spirometry specifically indicates early airway disease that conventional pulmonary function tests would completely miss. This is because spirometry measures larger airway function and is less sensitive for early changes, while the lung clearance index detects small airway dysfunction in the peripheral airways that are not captured by standard forced expiratory volume measurements. This has important implications for long-term monitoring of children after severe respiratory infections. Case 12. A 5-year-old girl develops empyema following community-acquired pneumonia. She has no recent hospitalization or antibiotic exposure. Blood cultures are pending, but pleural fluid analysis shows purulent material with numerous neutrophils. Physical examination reveals decreased breath sounds and dullness to percussion over the right lower lobe. Chest X-ray demonstrates a large pleural effusion with meniscus sign. Which bacterial pathogen is most commonly isolated from pleural fluid in pediatric community-acquired empyema? Option A, Haemophilus influenza type B. Option B, Staphylococcus aureus. Option C, Streptococcus pneumoniae. Option D, Streptococcus pyogenes. The correct answer is option C, Streptococcus pneumoniae. Streptococcus pneumoniae remains the most common pathogen in pediatric community-acquired empyema, accounting for 40 to 60% of cases. Staphylococcus aureus is the second most common organism at 20 to 30% of cases and is increasingly prevalent, particularly methicillin-resistant strains. Group A Streptococcus accounts for 10 to 15% of cases. Mixed infections occur in 5 to 10% of patients. Haemophilus influenza type B has become rare since widespread vaccination. An important note, methicillin-resistant Staphylococcus aureus prevalence varies significantly by geographic region, so local resistance patterns must always be checked when selecting antibiotic therapy. This is why empiric coverage with both a broad-spectrum beta-lactam and vancomycin is recommended until culture results are available. Case 13. A 5-year-old girl presents to the emergency department with 4 days of fever, cough, and right-sided chest pain. Physical examination reveals decreased breath sounds and dullness to percussion on the right lower chest. The emergency physician performs bedside ultrasound of the chest to evaluate for pleural effusion before ordering imaging studies. What is the primary advantage of bedside ultrasound over chest X-ray in evaluating pleural effusion in this patient? Option A, better visualization of lung parenchyma. Option B, detection of loculations and septations. Option C, assessment of cardiac function. Option D, evaluation of mediastinal structures. The correct answer is option B, detection of loculations and septations. Ultrasound is highly effective at identifying fibrin strands, septations, and loculations within pleural effusions, and these findings are crucial for determining the treatment approach. Simple effusions without loculations may respond to chest tube drainage alone, while complex loculated empyema often requires fibrinolytics or surgical intervention, including video-assisted thoracoscopic surgery or thoracotomy. This treatment guiding function is the primary advantage of ultrasound over chest X-ray. Ultrasound also guides drainage strategy, predicts treatment response, and avoids unnecessary procedures by accurately characterizing the complexity of the effusion before intervention. Chest X-ray cannot detect loculations, cannot characterize fluid complexity, and requires approximately 200 milliliters of fluid before it becomes visible, whereas ultrasound detects as little as 50 milliliters. Case 14. A 14-year-old previously healthy teenager presents to the emergency department with a 3-week history of gradual onset of low-grade fever, dry cough, and mild chest discomfort. The symptoms have been slowly progressive rather than acute. Physical examination reveals decreased breath sounds at the right lung base. Chest X-ray demonstrates a moderate right-sided pleural effusion. Laboratory studies show a normal white blood cell count with lymphocytic predominance. Which atypical organism is most likely responsible for this clinical presentation? Option A, Legionella pneumophila. Option B, Chlamydia pneumoniae. Option C, Mycoplasma pneumoniae. Option D, Coxiella burnetii. The correct answer is option C, Mycoplasma pneumoniae. Mycoplasma pneumoniae is a leading cause of atypical pneumonia in school-aged children and adolescents, with peak incidence between 5 and 15 years of age. Unlike typical bacterial pneumonia, mycoplasma infections present with gradual onset over days to weeks, persistent dry cough rather than productive cough, and systemic symptoms including headache and malaise disproportionate to the respiratory findings. The normal white blood cell count with lymphocytic predominance is characteristic and distinguishes it from typical bacterial empyema, which shows neutrophilia. Extrapulmonary manifestations are common and cold agglutinins are often positive. Crucially, mycoplasma has no cell wall, making it inherently resistant to beta-lactam antibiotics, including amoxicillin, cephalosporins, and penicillin. Effective treatment requires macrolides such as azithromycin or tetracyclines in older children. Case 15. A 5-year-old girl with a 3-week history of fever and cough develops a progressively enlarging, fluctuant soft tissue mass on her right posterior chest wall. The mass is tender to palpation and appears to be communicating with the pleural cavity on computed tomography imaging. She has a history of inadequately treated pneumonia 4 weeks prior. Vital signs show fever 38.5 degrees Celsius, heart rate 110 beats per minute, and respiratory rate 28 breaths per minute. Physical exam reveals a fluctuant 6 centimeter mass with overlying skin redness. Computed tomography shows a chest wall mass connected to the pleural space. What is the most likely diagnosis? Option A, chest wall abscess. Option B, empyema necessitans. Option C, necrotizing fasciitis. Option D, pleural fibroma. The correct answer is option B, empyema necessitans. Empyema necessitans is a rare but serious complication where infected pleural fluid extends through the parietal pleura into the chest wall soft tissues. This creates a visible chest wall swelling or mass, often with overlying skin changes including erythema and warmth and potential external drainage. The defining feature is the communication between the pleural space and the chest wall mass, confirmed on computed tomography imaging in this case. The condition typically occurs in chronic, untreated or inadequately treated empyema cases where the infection erodes through the anatomical barriers of the parietal pleura and chest wall. Key clinical features are visible chest wall swelling, skin discoloration or warmth, possible external drainage, and a history of chronic or inadequately treated chest infection. This complication powerfully emphasizes why early recognition and aggressive treatment of pediatric empyema is essential to prevent progression to these complex and dangerous stages. Are you looking for a structured way to access all of our pediatric case-based video lectures in one place? Our pediatric case review community gives you exclusive access to complete pediatric education resources. All lectures are organized by medical system for easy navigation so you can study systematically. Every presentation is available as high-resolution downloadable images, perfect for studying, reviewing, and practicing case-based questions at your own pace. The content is comprehensive and evidence-based, designed to support both exam preparation and clinical practice. If you are ready to elevate your pediatric knowledge and want to know the subscription details, simply comment below this post, and we will message you directly with everything you need. And that brings us to the end of today's comprehensive lecture on the management of pediatric empyema. We reviewed 15 high-yield clinical cases covering every major aspect of this condition. The core lessons from this lecture are 4. First, recognize empyema early through the pattern of antibiotic failure, persistent fever, and pleural effusion on imaging, remembering that stony dullness to percussion is the most reliable bedside sign. Second, use evidence-based management protocols, thoracentesis for diagnosis, chest tube drainage for significant effusions, fibrinolytics for loculated disease, and surgical intervention for refractory cases. Third, master diagnostic imaging interpretation, especially the split pleurosign on computed tomography and ultrasound detection of loculations and septations. Fourth, recognize and manage complications including bronchopleural fistula and empyema necessitants promptly. Please follow Pediatric Case Review for more weekly case-based presentations. If you have questions or want to request specific pediatric topics for future lectures, comment below and we respond to every inquiry.